Hi there, this is Kiffer with Week 7's lecture covering material from Chapters 16 and 17, which you should have or will read this week. In previous weeks, we've covered case control, cross-sectional cohort study designs, and as you can see on slide 2, we'll be discussing some hybrid designs, along with ecological studies and randomized controlled trials. On slide 3, if you recall from earlier weeks, epidemiologists are often interested in the effect of an exposure variable on an outcome. We've introduced to you the prevalence ratio, which is used in cross-sectional studies, the odds ratio, which is often used in case control studies, and the risk ratio, which is used in cohort studies. All of these are valuable tools that allow us to assess the effects and the association between variables. But today I wanted to introduce you to one more called attributable risk. As you can see on the graphic here, attributable risk is the difference between incidence in the exposed and the incidence in the unexposed. Conceptually, you can imagine that there is some baseline level of disease in a population, and the attributable risk aims to tell you how much of the disease in the exposed group is above and beyond the baseline level of risk. Similar to the attributable risk is population attributable risk. And the primary difference here is that the attributable risk is primarily concerned with just the exposed group, whereas population attributable risk answers the question of how much would the incidence decrease in the population should the explanatory variable change or cease to exist. Both attributable risk and population attributable risk are presented as rates. So for example, you might say that 23 per 100,000 heart attacks are attributable to smoking. And both attributable risk and population attributable risk can be communicated as risk percents, which reframe these rates as proportions, allowing you to say something like 6.2% of heart attacks in the population would be avoided if smoking was eliminated. Another relationship not shown here is the preventative fraction, which is basically just the inverse of the attributable risk, and is used when the exposure has a protective rather than detrimental effect. On slide 4, we move into some of the study designs that might be used to generate these sort of statistics that epidemiologists are interested in. The first of these is a modification of the cohort study, and is just a retrospective cohort, which is basically the same thing. It's just usually conducted using historical data like medical records. These studies are often used because they are cheaper and faster than prospective cohort studies, because you don't necessarily need to follow people for long periods of time or pay individuals to come back into the study. Oftentimes this is conducted using secondary data, which means that you have less control over the data and data quality and the questions that were asked, and the findings are possibly outdated, but overall it's a pretty good substitute for a retrospective cohort, and especially very cost-saving. In slide 5, you see we have another variation of the cohort study, where within the framework of a cohort, we identify all the cases and controls and use them as a study population to identify other exposures of interest that might have also been reported on as part of the cohort study. Other than that, the nested case control study is essentially the same as a regular case control study. You just have to be careful to control for the original sampling strategy and make sure that you're not obscuring anything important, because you can remember that cohort studies often recruit based on exposed and unexposed populations. And so if you're investigating something that's related to that exposure, you may want to control it, which is often the case that you are. On slide 6, we have a similar thing going on as what was in the nested case control study. This is called a case cohort study, except these are quite a bit more complex and procedurally and analytically. As you can see, they're not widely used. You may have not ever heard of a case cohort study, but they are increasingly becoming important tools. You might want to think about what's going on here, because I think the diagram is maybe a little confusing. But essentially, a case cohort study, your goal is to reduce the number of subjects for which a specific variable must be collected on. For example, if you were going to collect genetic sequencing or biological specimens, which can be a bit pricey, you might want to just collect these specimens for a small fraction of the overall cohort. So to ensure that you have a sub-cohort representative of the overall cohort, you take a random sample of the study cohort and collect the variables you're interested in for only those people. Then, as time goes on, you identify cases, and you collect the variable of interest for these persons too. You can then compare the cases to the control group, which in this case is the subcohort. And using some statistical adjustments to account for error and overlap in these groups, the analytic side of these cohorts is probably outside the scope of this course, but when you do that process, it enables you to have a representative subcohort that's of your cohort so that you can collect just a smaller set of variables or a larger set of variables among that smaller set of people. The one thing that you should readily recognize is that the assessment takes place at different times for the subcohort and the cases. Oftentimes with the subcohort it's taken at baseline so that you don't have problems with loss to follow-up, whereas for the cases it's not taken until that person develops a symptom. So you have to be careful that your variables are not time dependent and that your samples, if they're biological or genetic, that they don't degrade. On slide 7, I introduced to you a case crossover studies by highlighting the difference between within subject and between subject study designs. In short, a case control studies are just those that look at within subject variants, where an individual is used as their own control subject. This helps to eliminate within person bias and also helps with some specific research questions. For instance, if I were interested in assessing whether condom use was associated with alcohol consumption before sex, I could ask people about their recent sexual encounters and determine if condom use was more or less likely during the specific events in which they did or did not use condoms. And so you can see it can give me a greater description of causality, and it can also help you to control for a lot of those within-person effects. These type of studies have been important, especially in environmental epidemiology, and they played an important role in linking air quality to health outcomes. In these examples, historical air quality data can be used to determine if participants were more likely to present with breathing problems, maybe in a doctor's office or in a hospital, on bad air quality days versus good air quality days. And because the data is within person, it controls for whatever those between person confounders might be and might otherwise trouble your study. On slide 8, I provide an overview of the strengths and limitations of these few hybrid designs that we've talked about, and show you relative to their counterpart what are their strengths and limitations. As you can see, for the most part, these hybrid designs are mostly conducted out of convenience. They save money, they save time, and they take advantage of existing resources. And they shouldn't be overlooked just because maybe they have a few different or maybe some limitations. But I think it's important to be aware of all of them. Okay, so starting on slide 9, we see the basic outline for a randomized control trial. Randomized control trials are considered the gold standard. As you can see, the primary difference between this and a cohort study is that you are randomly assigning individuals to an experimental and control or placebo intervention. So these are often used like to test the efficacy of an intervention, such as a pill or a clinical visit, maybe a specific surgical technique, but really they can be applied to a lot of different things. On slide 10, you can see that oftentimes the assignment is blinded for both the researcher and participant. Single blinding is when only the participant is blinding, and it often uses placebos, or is increasingly the case, you just compare it to the existing standard of care and see if your new intervention is better. However, while single blinding controls for participants reduce bias and lessens the loss to follow-up, there is still the potential that the researcher might treat patients differently based on their exposure status. So oftentimes, RCTs should be double-blinded, where neither the researcher nor the participant knows they are being administered the intervention or the placebo. As you know from our earlier discussion on randomization last week, this study design is quite robust because it randomizes the sources of bias between the two groups and ensures that new bias is not injected throughout the study procedure. On slide 11, I show you the kind of standard clinical trial phasing. Phase 0 or preclinical trials are used just to test the potential effect of a clinical, therapeutic, or prophylactic drugs. About 40% of these make it to patient testing in phase 1 trials. However, there are usually quite small, probably averaging only about 20 patients. These phase 1 trials focus mostly on safety and tolerability. About 75% of those in phase 1 make it to phase 2, where dosing and safety are both evaluated. And this is probably the first study design where you start to see some controls in place. About half of those in phase 2 make it to phase 3 trials, which are usually what we kind of treat as the gold standard quote-unquote clinical trial, where you have randomization, you have blinding, you have placebo, you have a control group, and you've read about these this week. So about 64% of those then make it to market and are evaluated for long-term safety and effectiveness. And this includes cost effectiveness and effectiveness of the drug in like a diverse population, because oftentimes you've done things like restricting and matching in previous stages to really try to tease out the effect optimally. Overall, the process from phase 0 through phase 3 can take 10 to 15 years, and the success rate is only about 10%, I think 8% on there on the slide. This is why drugs can be so expensive, and because for every successful drug that a pharmaceutical company probably provides, has to fund probably about 10 or more other drugs over time to finally get one to that point. On slide 12, I can provide you some of the benefits and limitations of randomized controlled trials. Particularly, there's ethical limitations. You can't always randomly assign an outcome. There's differential loss to follow-up sometimes. You know, if the placebo arm is dying off quicker, or if there's declining interest in the placebo group, or whatever the case might be, there are reasons that could happen. Oftentimes, they halt clinical trials if something really perverse is happening, and it seems that the intervention is quite, powerful or effective. They halt it because they don't want to deny that control group the opportunity to be treated. Oftentimes, the recruits are optimally healthy in these randomized control trials, and so you have a little bias in representativeness issues. And usually, this is done because researchers want to show kind of the optimal effect of the intervention. And if you have people who are difficult to progress, then oftentimes they will kind of lessen the effectiveness of your results. And so it's important to remember that despite being kind of the gold standard of epidemiology and medicine evaluation, they are not without error, and you still have to be careful in their implementation. On slide 13, I introduced to you some ecological studies. Ecological studies, as you may know, show correlation but not causation, as is often the case with any observational study design. However, even a strong association found in an ecological study may not accurately reflect the real world. This is because observational data uses clustered data that doesn't actually assess exposure on specific individuals. As pictured here, you can see an example of what we call the ecological fallacy, in which basically shows an example of how a relationship between clustered data might not be reflected in the person-level data. In this case, it looks like some other factors might be influencing people's relative position on these axes. But when you actually look at the within-cluster relationships, it's actually not as good as you thought, and it could really be the relationship could be anything as shown there. And so you have to be really careful when applying results reported about clusters and applying those results to populations. With that said, as you can see on slide 14, there are actually population-level analyses which can be quite useful. One example is a community trial, where an intervention is applied to the group or community level. This strategy is advantageous because it gives you a sense of how an intervention might work in the real world. In this case, I've put together on this slide, you can see that within each community or region, we randomly assign schools to one of 3 interventions, maybe based on community. This would allow us to compare and contrast the outcomes of these schools, and assess which interventions had an impact that you were looking for. This sort of study design is often referred to as quasi-experimental because it's not quite as rigorous as what we might expect out of a randomized control trial. And so to eliminate confounding in these studies, usually you just boost the number of samples or you randomly assign the intervention in that large sample so that you kind of take advantage of the laws of probability in the distribution of things. So oftentimes it's difficult to do that. You have politics, you have principals who maybe don't want to see a specific intervention take place. And so often the case is that community trials are opt-in and opt-out, and so you kind of lose control that way. So these real-world trials, while providing a nice way to test large-scale interventions, can sometimes be overcome by confounding. And I think that highlights nicely the population and community level work can indeed be rigorous despite the ecological fallacy, and so I think they're still important to kind of be aware of that not everything collected on an ecological level is necessarily going to be overburdened by the ecological fallacy. On slide 15, I conclude with a short listing of the strengths and limitations for ecological studies. And starting on 16, I provide you some review questions that you can work together via the discussion boards or elsewhere all by yourself. Now that we've presented all of the study designs that you will need to know for this course, you can go back and look at all of their strengths and limitations in the slides I provided over the past 3 weeks. And the material there in the slides will help you to kind of get a better sense of when it is you might use these. If you've done the previous week's study guide questions, oftentimes they've asked you to think up scenarios in which they might be used, and hopefully you're searching the literature to do that. And so with that, good luck and on the review, and I look forward to chatting with you on the message boards. Okay.